Okay, I think we'll start. I'm Marcia Stefanik. I'm the director of the Wisdom Center, which is the Women and Sex Differences in Medicine Center. We actually did our spiel over in the other room, so I'm not going to tell you about our vision and our mission. I'm going to move right on into our women's cancer, our speed panel on women's cancer, and each talk will be 15 minutes, and then the questions will be at the end. There'll be a 15-minute panel. Anousheh Agahi is going to be presenting on genetic testing and screening in breast cancer. And then we're going to have Sigurdis Haraldsdottir, who actually goes by Cece, who is going to be talking about which cancer? Cervical cancer, colorectal cancer, that's right. This isn't all women stuff, colorectal cancer. And then Oliver Dorigo will be talking about ovarian cancer. So I'm just going to ask Dr. Agahi to come over and present the session.
Thank you, and thank you for having me. So my name is Anousheh. I'm an instructor here at Stanford, and I see patients with breast cancer. And let me just figure this out. So the title of my talk today is Advances in Genetic Testing, Screening, and Prevention of Breast Cancer. Please let me know if you can hear me, and I'll try to speak louder. This is just a simple schema looking at the progression from normal tissue to malignant or cancerous tissue. So the normal tissue is on the far right, and then you go on to malignant tissue. And then the third image here is an image of a breast cancer patient, and this is a bone scan showing that she has now distant spread in her bones and her spine. And unfortunately, at this currently, we are unable to cure most patients with distant cancer spread, and so this usually leads to an early death. Initially, our focus was really treating distant cancer spread, and that was primarily in an effort to palliate. But in the more modern era, our goal is really to focus our efforts on prevention and early detection to really reduce the morbidity and mortality of breast cancer. And this is in an effort to really focus our attention on personalized medicine. And one way in which to do that is to focus on genetic testing, which is what I'm going to be talking about next. So we know that cancer is a genetic disease, and the underlying genetic defect primarily is genomic instability, meaning an increased mutational load over time. Culprit genes include those involved in proliferation, apoptosis, which is programmed cell death, and DNA repair. So these are the spell check genes to make sure that errors are not propagated in your DNA. Most cancers have mutations in many of these genes, and inherited cancer syndromes are often due to mutation in these specific genes, including BRCA1 and 2, which is two genes that we're going to focus on in this talk. And these are associated with the highest cancer risks in the general population. This is a schema of a human karyotype. In the normal cell, we have one copy from our mother and one copy from our father. And in terms of cancer development, if we focus on the non-hereditary woman, and again, our focus is breast cancer here, she is born with two normal genes. So she's on the far left here. Right here. So she is born with two normal genes, and throughout her life, something, oftentimes we don't know what happens, and so she ends up having one damaged gene. However, she still has that functional second gene, so she doesn't have cancer at this point. But if there is another event, and this is called a two-hit hypothesis of cancer, that leads to a loss of the second normal gene, then she has a high risk of developing cancer. Now, if you see the second schema here is the case of someone with a hereditary syndrome. So either her mother or father had one damaged gene, such as BRCA1 or 2, and so she inherits that already. And so it's just a one hit in this case. So if she loses the normal gene, she now is at higher risk of developing cancer. And so just by looking at this diagram, you can sense that a patient or a person who has this hereditary risk can form cancer at an earlier age, and this is what we see. And they're also at a higher risk of not just one cancer, but multiple breast cancers and multiple cancers in general, not just breast. Now, it's important to know, though, that an inherited mutation does not equal cancer. It increases your risk of cancer. However, there are certainly patients or people who have a BRCA1 or 2 mutation or other cancer sort of mutations that increase risk but do not have cancer. So why is this? There are other variables involved in cancer formation, including modifier genes, our body's response to DNA damage, carcinogens such as smoking, and hormonal, reproductive, and lifestyle factors. So again, not everyone with an inherited mutation does get cancer, and that's important to know. This is looking at cancer cases and deaths in the United States using the American Society of Cancer registry here. So on the right, you see the estimated new cases in 2016. We see that prostate cancer is at the highest in terms of new cases here in the United States for males, and breast cancer for females. However, when you look on the other column, the estimated deaths, in fact, lung cancer is the highest risk of death for both men and women, and breast cancer is second for women. And this is in part due to our improved interventions in terms of screening and prevention for breast cancer. The average lifetime risk of developing breast cancer remains 1 in 8, or about 10 to 12% in the average population. This is a little bit of a busy slide, but just to show the different factors that are involved in increasing someone's risk of forming breast cancer. So of course, being female is of highest risk. The two highlighted columns here, BRCA1 or 2 and family history, they are at the highest magnitude risk factors, so they are the genetic risk factors. But certainly there are a lot of other factors that are at a less increased risk but more common in the general population. And those include high breast density, and we'll touch on that a little bit, age at first live birth being above 30 years, the use of hormonal replacement therapy, and then just lifestyle factors such as diet, alcohol, exercise, things like this as well. This diagram is a little bit old now, but just to delineate some of the factors and some of the genetic modifications that are involved in cancer formation. So I'm going to walk this with you. So just showing on the y-axis or the vertical axis here is the relative risk of cancer development. So this means that the risk increase compared to the average person in the general population. And on the x-axis or the horizontal axis is the allele frequency. So you see, for example, BRCA1 and 2 are up here. So the risk of cancer development with a BRCA1 or 2 mutation is relatively high, but the allele frequency in the general population, so the frequency of having this in the general population, is relatively low. Now, in the past couple years, we've actually introduced multi-gene panel testing, meaning that we can test not just 2 genes, but an array of genes, up to 40, 50 genes. And so we're now detecting multiple other genes that are implicated in cancer development. And so genes such as PALB2, you might have heard of that one in the news, ATM, CHEK2, these are genes that have a less relative risk of cancer formation, but that may be more common in the general population. So we're still trying to figure out what to do with patients who have one of these genes in the clinic. So why can we now do multi-gene testing? Part of it is because of our innovations in basic sciences. We can now sequence the whole exome, and with that is also a reduced cost in these techniques. So a whole exome sequencing is now about $1,000, which is much less than it was a decade ago. So there's just a tremendous increase in the technology that we have with an associated reduced cost. Furthermore, there was a landmark Supreme Court ruling in 2013 that basically said that you cannot patent genes. And that led to the main company who held the patent for BRCA1 and 2 for over 20 years to be unable to keep that patent. And pretty much the second day that that ruling happened, multiple other companies were able to offer genetic testing for BRCA1 and 2. And in order to improve, in order to be more competitive in this market, different genes offered different arrays of, different companies offered different arrays of genes to be tested. So beyond 1 or 2 genes, and they offer this for a much lower cost. So rather than just being able to test for BRCA1 and 2, we now offer large panels of gene testing when a patient comes in who is interested in having this done. The second thing that happened in 2013 that also improved our clinic volumes was what we call the Angelina Jolie effect, where she wrote an editorial in the New York Times about her experience with a BRCA1 mutation and her personal decisions in terms of risk reduction. And that really increased a lot of women's awareness and also their desire to be seen by cancer genetics. So the Stanford Genetics Group's experience with these multi-gene panels was recently published. And this is just to show that this is what happened was we asked patients who came in for BRCA1 and 2 testing if they also wanted to have a research sample at that time to test for these other genes. And what we saw that about 10% of these patients had another gene implicated that increased their risk of breast cancer, the same probability of having a BRCA1 and 2 mutation in this patient population. We also saw that variants of uncertain significance. Now these are alterations in the genome that we don't really know the implications for, whether they're harmful or not. They were quite common. Interestingly, all patients who had the testing done wanted to know about their results. And even in this small patient sample, we actually saw that it changed care in one case of a patient who was found to have a defect that not only increased her breast cancer risk, but also her risk of colon cancer. She was recommended to have a colonoscopy and indeed found the precancerous lesion. So this was actually something that benefited the patients in clinic. Moving on briefly to screening and prevention. Currently, the American Cancer Society recommends mammography starting at the age of 40 and then yearly then on. Furthermore, we recommend clinical breast exams every 1 to 3 years starting at the age of 20 and then yearly at the age of 40. Self-breast exams monthly starting at the age of 20. However, this is not enough for high-risk women, and this is just to show that women who are younger have more dense breasts, and this can have a kind of make it harder for us to detect lesions on mammography. So here again, on the right here, you see a fatty breast, and then on the very left here, you see a breast that's dense. Now, density shows up as white on a mammogram, as does a lesion, and so that makes it very difficult if someone has dense breasts to really detect these cancerous lesions. We now have 3D mammography or tomosynthesis here at Stanford, and that can help. And this is just to show, in case some of you might have been offered this technique. This is the machine used, and this is just a paper that was recently published that shows that it does reduce the recall and increases the cancer detection rates in both dense and non-dense breasts, but primarily in women with dense breasts. MRI breast is also a technique that we recommend primarily for women who are younger, who again have dense breasts, or who have a higher risk of cancer development, primarily due to an underlying hereditary syndrome. This is a 30-year-old female who has a BRCA1 mutation. Again, she has a very dense breast on mammography, and her lesion was not able to be detected. But then here we see the central lesion on the MRI that was proven to be cancerous on a biopsy. Furthermore, we have surgical cancer prevention techniques, including prophylactic mastectomy. Again, this is in the setting of someone who has a very high risk of developing a breast cancer. And this involves removal of both breasts. It's about 95% effective in preventing a breast cancer. However, most women who are offer this do prefer to have high-risk screening rather than removal of both breasts, which makes sense. The other issue here is that a lot of these patients who have an increased risk of breast cancer, who have a hereditary syndrome, are also at an increased risk for other cancers. With a BRCA1 or 2 mutation, you also carry an increased risk of ovarian cancer. So we also offer prophylactic oophorectomies, and this includes removal of the ovaries and the fallopian tubes. And this also is very effective in preventing ovarian cancer and also reduces the chance of breast cancer if a woman is premenopausal. Because we don't have very good screening techniques for ovarian cancer, this is recommended by the age of 40 if you do have a BRCA1 or 2 mutation. And I know I'm running out of time, but just briefly to say that we also have medical breast cancer prevention options that are not used as frequently as we would like. So both tamoxifen and exemestane or aromacin are anti-estrogen therapies that we use for women who have breast cancer, but they've also actually been shown to be effective in reducing the risk of even developing a breast cancer if you're at a high risk, up to 50%. Unfortunately, these are not used as often as we would like. And then finally, just to show lifestyle choices, certainly low-fat diet, reduction of alcohol, and exercise have been shown to have trends towards an improvement in reducing breast cancer risk. And with that, I'm going to close this, and thank you all, and we'll take questions at the end. Thank you.
Well, good morning, everyone. I'm a medical oncologist at Stanford, and I'm delighted to be here to talk a little bit about colorectal cancer and precision medicine. And I want to start this off by quoting one of my fellow physicians who's a medical oncologist at USC. And he said, "We may never understand illnesses such as cancer. In fact, we may never cure it. But an ounce of prevention is worth more than 1,000,000 pounds of cure." And that's why I really want to focus the first half of my talk on how we can prevent colorectal cancer. So colorectal cancer is the third most common cancer in the United States. It's right after prostate and lung in males. Let me see. Okay. And it's after breast and lung in females, represented by the blue line. Now, one of the good news is that the incidence of new cases has been on the decline for the last 20 to 30 years. We think that some of that has to do with some lifestyle changes, but more importantly, screening colonoscopies have become routine, especially after the 1990s, and covered by Medicare from year 2000. We think that 2/3 of colorectal cancer could be prevented if everyone had their screening colonoscopies. So what is a colonoscopy? Well, so that is a tool where we thread the colon with a videoscope. With a sigmoidoscopy, we take a look at just the left side of the colon, but if people have a full colonoscopy, we visualize the entire colon. And by doing so, we can identify cancers, hopefully at their earliest stages, and we can identify polyps and remove them, which can be precursors to cancer. Now, this is the gold standard of detecting colorectal cancer. But if this is something that is very unappealing to people, we do have other tests that can be helpful. Stool tests look for blood in the stool, where people smear some poo on these tests and send them in. But the caveat is that you have to do this every year in order for it to be effective in detecting colorectal cancer. So let's talk about risk factors, and maybe more importantly, what can lower our risk of getting colorectal cancer. So for most of us in this room, the lifetime risk is about 5%, slightly higher in males than in females. If we belong to that average risk category, it is recommended that we start having screening colonoscopies at age 50, and if it's normal, we go for one every 10 years. And so there are other risk factors that can increase the risk significantly, and maybe most importantly, inherited cancer syndromes. Lynch syndrome being the most common of those, causes about 2 to 3% of all colorectal cancers. And if people have Lynch syndrome, they need to start colonoscopies much earlier. They need to go every 1 to 2 years. We also have more rare syndromes, the so-called polyposis syndromes, where people develop multiple polyps in the colon. The cancer risk can be quite high with many of these syndromes, and there are specific guidelines in terms of scopes if people have these syndromes. So I want to talk a little bit more about Lynch syndrome. So we think that upwards of 1 in 300 individuals carries Lynch syndrome. It increases not only the risk of colorectal cancer, but also endometrial and ovarian and other gastrointestinal cancers. And so in this case where we show an affected father who is born with a mutation in one of the Lynch syndrome genes, right here, so he has a 50% chance of passing that off to his children. And so there's been a huge push in the United States and in the world to try to identify these individuals because we want to be able to screen them and prevent these cancers from happening. And so now we're doing what we call universal screening, meaning we're testing all colon cancers that come into Stanford, and other cancer institutes are doing the same thing to try to identify these. This is done by microsatellite testing or staining these tumors for these proteins. So what other risk factors do we have? Well, there are people who have inflammatory bowel disease, such as ulcerative colitis and Crohn's, have an increased risk, upwards of 40% lifetime risk, and they should start getting screening colonoscopies about 8 to 10 years after they're diagnosed with this condition. Family history is important. If you have a first-degree relative, meaning a parent or a sibling who has been diagnosed under the age of 60 with colorectal cancer, you should start having colonoscopies at age 40 or 10 years before your family member was diagnosed. You should go more frequently or every 5 years for a colonoscopy. And then certainly if people have a personal history of cancer or polyps, there are specific guidelines where you go in for screening colonoscopies more frequently. And then we have a bunch of modifiable risk factors, and I apologize, this slide got cut off a bit. But modifiable meaning we can do something about them. They don't increase the risk as much as some of these non-modifiable risk factors. But these are obesity and diabetes. Definitely diet has a lot to do and is an important risk factor. And so is smoking and alcohol. But if we have these risk factors, they don't change the screening guidelines. We still go for a colonoscopy at age 50, and then every 10 years if it's normal. So what can help prevent colorectal cancer? Well, aspirin has been shown to reduce the risk by about 40% if people take a daily baby aspirin for at least 10 years, and if people start at age 50 to 59. So this is now recommended. And actually, the guidelines for this are somewhat complex because you can have an increased risk for bleeding, and you have to be willing to take it daily for at least 10 years. So I recommend talking to your primary care physician before starting this. So what other factors protect us from developing colon cancer? Well, we talked about the importance of colonoscopies. It's definitely important to maintain an active lifestyle, if you're overweight or obese, to lose weight, to drink alcohol in moderation and lay off smoking. And then it's important to avoid this, what we call the Western diet, or the hamburger diet, the sodas and pizzas and burgers and donuts, and instead try to adhere to something more like this, the Mediterranean diet, meaning fruits and vegetables and fish and chicken and whole grain. So what about people who have already been diagnosed with colorectal cancer? What kind of lifestyle changes should they make? Keep in mind that we divide colorectal cancer into 4 stages, and in stages 1 to 3, surgery is really the mainstay, sometimes with the addition of chemotherapy. And in stage 4 metastatic disease, chemotherapy is usually the mainstay of therapy. But I really want to talk about what else we can do besides these therapies. And so we've actually done quite a few studies looking at lifestyle factors. Most of these have been done on patients with stage 3 disease, meaning it's localized colorectal cancer with involved lymph nodes. And so we know that the patients who adhere to that hamburger diet, they actually have worse outcomes than people that eat more healthy. Same with a high total sugar intake and people who drink lots of sugar-sweetened drinks, they have worse outcomes. People who are obese have worse outcomes as well, and we know that people who stay active, they have a better survival. We've looked at vitamin D levels, and people who have high vitamin D levels in the blood, they tend to do better as well. And then aspirin has been shown to improve outcomes in patients with colorectal cancer. So what do we recommend for our cancer survivors? Well, we recommend that they maintain a healthy weight, that they maintain an active lifestyle, out and about at least 5 times a week for 30 minutes, consume a healthy diet with lots of vegetables and fruit, and limit those processed foods and red meats. Limit alcohol use to 1 drink per day for women and 2 drinks per day for men. And then for my patients, I do recommend a baby aspirin daily and vitamin D3 if they don't have any contraindications. So let's talk a bit about precision medicine and how that's impacting the care. And so first of all, what is precision medicine? Well, that's the idea that by taking into an account an individual's variability in genes, environment, and lifestyle, we can individualize therapy for that person. And more importantly, in oncology, if we could understand what drives a tumor, then that could give us a target to go after, either with our chemotherapy or targeted therapies or immunotherapy. And so we've made great strides in the last 30 years in trying to understand what drives colon cancer. And one of the early discoveries was made in 1987 when investigators found that normal mucosa in the colon can over time accumulate mutations in specific genes, and that leads to polyp formation, initially benign polyps, but then later they can become cancerous, and this process takes over a decade usually. Today we know that we can use some of these mutations, specifically the mutation in RAS, to help us decide who benefits from certain targeted therapies, more specifically therapies that target the epidermal growth factor in metastatic disease. And we know that patients who have tumors without a RAS mutation, they tend to respond to these therapies. So we use that to select patients for the therapies. So this is Henry Lynch. He discovered Lynch syndrome, that inherited cancer syndrome that increases the risk of colorectal cancer. We know that these tumors, they develop via something called the microsatellite instability pathway, and that can both be caused by Lynch syndrome, the inherited phenotype, or can happen sporadically in the tumors. But these tumors, they will collect a lot of mutations. And so today we actually use this to help us decide on therapies. In localized colorectal cancer, we know that about 15% are microsatellite unstable. And we now know that these patients don't benefit from chemotherapy in stage 2 disease. And then in metastatic colorectal cancer, we know that about 4% are microsatellite unstable. And these seem to be the patients who are responding to immunotherapies. And this is really, immunotherapies are not approved yet for colorectal cancer. This is ongoing in clinical trials, but we've seen some amazing responses in this population. And then the Cancer Genome Atlas data in colon cancer came out in 2012. This was a huge effort orchestrated by the NIH and others to try to sequence colon cancer and try to understand what the drivers are. And I mean, the results have been quite complex, and I would say the scientific community is still trying to sort out this data in order for it to help us treat patients. So what are the take-home points? So you should know your family history. You should go in for a screening colonoscopy at age 50, but you may need it earlier if you have a positive family history. An inherited cancer syndrome, certainly, or inflammatory bowel disease. We should all adopt a healthy lifestyle, meaning a diet filled with fruits and vegetables, be active and maintain a healthy weight, avoid smoking and consume alcohol in moderation. And then in terms of precision medicine, I think it's important for people who have been diagnosed with colon cancer that they have been screened for Lynch syndrome and microsatellite instability. So this is our multidisciplinary team. So I'm with medical oncology, but we work closely with colorectal surgery and the gastroenterologists who do the scopes, and then people in the genetics clinic who help us sort out the cancer syndromes. Thank you.
I'm going to start with saying a big thank you to Dr. Stefanik to first putting on such a great educational symposium for women. I think that's extremely important, and I want to thank you also for inviting me to speak here. I'm going to talk to you about immunotherapy for ovarian cancer because, like the last speaker alluded to, we have made some really great and promising progress in immunotherapy in many cancers, including gynecologic cancers. I'm also always fascinated by presentations like the ones that I just heard because we have a lot of things in common. Colorectal cancer, breast cancer, as you just saw, has a lot of genetic changes that we don't only find in those cancers, but we also find them in ovarian cancers and other gynecologic malignancy. And what's further interesting is that immunotherapy works probably the best in those cancer patients whose tumors have a lot of genetic changes, and I'll show you some of this data. So in other words, we're moving very close together, and we have a fabulous program here in genetics at Stanford that helps us really understanding who responds to immunotherapy, who are the patients that we should really enroll in these trials. So as shown here on the slides, I run the division of Gynecologic Oncology here. I also have a research lab. We're very interested in immunotherapy, and our clinical trials are very much focused on immunotherapy for ovarian cancer. So what I'll show you today is why do we think immunotherapy is going to work for ovarian cancer? And I think in particular interesting are those what we call immune checkpoint inhibitors that target molecules like PD-1 and PD-L1. And then in my last part, I know only have 15 minutes, but I want to show you a couple of very novel immunotherapy strategies in ovarian cancer here in clinical trials at Stanford. This is a landscape. I know you just saw a slide from 2016. This was what we looked at in 2015. Endometrial cancer or uterine corpus cancer is still the #1 gynecologic malignancy with now, I think in 2016, 60,000 new cases. And that has much to do with the huge wave of obesity we've seen in our, unfortunately, adolescents and children even, that increase your risk of developing endometrial cancer much earlier in life than we have ever seen that. Ovarian cancer is not even on the top 10 list here on the left side, but it's responsible for a lot of death in females, as you can see on the right side. And that's a number that's very concerning. In general, about 2/3 of ovarian cancer patients present with advanced disease, and those patients have about a 30% 5-year survival. It's much different in the early stages, where the survival is over 90% if we can detect ovarian cancer early on when it's still confined to the ovary. I'm going to focus a little bit on the immune system today, and this is what it looks like. There's a lot of different cells in the immune system. This is a very simplified overview. It's still complex. On the left side is what we are born with, what we call the innate immune system. And again, that has a lot of cells in there. These cells don't really need to understand what to do because they know this when you're born. They just fight foreign invaders, bacteria, cancer cells. But they do it in a very unspecific way, meaning they don't distinguish necessarily between a cancer cell and a bacterium. They just eat it up because it's foreign. On the right side, though, are the cells that we are more interested in almost in immunotherapy. And those are the so-called B cells and T cells. And those cells actually have to be instructed on how a foreign invader or cancer cell looks like. They make antibodies. In case of B cells, you all know antibodies. They're very specific for certain proteins. Likewise, T cells, we have several subsets of T cells, but some of them are extremely effective killing cancer cells. And those are the cells that we have now used in clinical trials to fight cancer. We have understood much about the way that cancer presents itself. And if you start down here at the pointer, I don't think it's working, but let me give this a try again. Yeah, here. So a tumor here can release proteins into the systemic circulation. And in lymph nodes, it shows it to the immune system in a way that activates the immune system. And then you have these specialized cells, particularly T cells, that travel to the tumor and here can kill the tumor. Now that's all good and fine, but T cells, if they were so effective, would not allow tumor growth, but we still grow cancers. Now why is this happening? Well, the cancer has built up a very strong shield around itself. That shield has a lot of different components, a lot of ways that cancers do this, and some of this very important shield is consistent of this here, PD-L1 and PD-1, those immune checkpoints that are preventing the immune system from attacking the tumor. So it grows because, not because the immune system is not intact, because the tumor defends itself. Now, do you think that ovarian cancer immunotherapy will work? Yes. We have, over many decades, actually done trials with interleukin-2, with patients in platinum-resistant disease. It's actually worked. There were 4 complete responses. Those are platinum-resistant ovarian cancer patients that don't respond to chemotherapy, but their tumors shrink away. The reason why we don't do this is because it's not approved by the FDA, it's cumbersome, has a lot of side effects. Other trials have used those lymphocytes, white cells that infiltrate the tumor tissue. We have expanded them in cell culture and put them back into patients. That also has shown some initial efficacy. At that time, it just wasn't as sophisticated as it is nowadays, as I'm going to show you. Furthermore, we have seen that when you look at tissue from ovarian cancer patients, all in brown here, those are the white cells, the T cells that I talked about. Those are the good ones that fight the cancer. If you have in your tumor as a patient a lot of these T cells, your survival is much better compared to patients whose tumors do not have T cells. So these T cells play a major role. And we have confirmed this by other studies here. This is now a few years ago. And those were the landmark studies that suggested to us ovarian cancer immunotherapy can actually work. In addition, and you just heard that colorectal cancers, 4% of these patients have a high degree of genomic instability. Their DNA breaks in pieces, they can't repair it very well, and they have a lot of genetic mutations. Now, is that true also for ovarian cancer? Here is a graph that shows you how many mutations are found in our gynecologic malignancy. Ovarian cancer is here, endometrial cancer, and cervical cancer. While we're beaten by melanoma, lung, bladder, and so forth, and colorectal cancer right next to endometrial cancer. But our cancers have a lot of genetic mutations, and therefore we think they are responsive to immunotherapy. How does this work on a cell-to-cell basis? I told you that we want to get these T cells to kill the tumor cell, but the tumor cell prevents that from shielding itself. And one of the most important ways it does it, I know there's some biology here, but I hope that makes some sense. Here's a tumor cell, here's a T cell. The T cell sees the tumor cell by this here, a receptor on it. And unfortunately, by PD-L1 and PD-1 interaction, this T cell is inhibited. But not only that, as the tumor grows, these T cells push the tumor, making more of the shield. So by attacking the tumor, they're increasing the thickness of the shield, if you want to put this in very simple terms. Now imagine we have a drug that breaks that axis here and blocks that immunosuppressive shield. Well, we have drugs for that. Here's a trial I want to show you. That's called Nivolumab. Doesn't matter what it's called, but that's the name of it. There's other drugs out there. Those drugs were given to patients breaking this PD-L1, PD-1 interaction. Those are patients with very advanced ovarian cancer. All of them did not respond to any chemotherapy. And I show you the CT scans of 2 of these patients on this trial that only had 18 in it in Japan. Those are, on the left side, 2 patients with a large amount of tumor, 7-8 centimeters. Look at these big masses here. Those are the kidneys. After 4 months, these are completely gone. And I have to tell you that in all these years of clinical practice I've been in, I've never seen a response like that. That corresponds with a drop in CN25. And in addition to this, when you look at the time frame those patients with CRs, complete responses, do this for over a year and going on. And that is also something we have not seen before in platinum-resistant ovarian cancer. 2 patients here, there are others that responded and other trials going on, but in essence, I think, very, very promising approach that we are now investigating with a vengeance further. What we don't know is what patients will respond to the immunotherapy. And I was just talking about the genomic instability. Well, genomic instability is probably just one factor. There's others. And this schema here shows you that we are going to look at the lymphocyte, the white cells in the tumor, how much PD-L1 is being made. Macrophages are also part of the shield. It's a very complex shield. Can be target macrophages to get anti-tumor responses. So a lot of, I think, interesting strategies in the area of targeting the immunosuppressive axis in ovarian cancer. Now, what do we do for immunotherapy trials here at Stanford? I told you that we have a huge interest in this. As a matter of fact, the Stanford Cancer Institute has just really put a lot of emphasis on building a very, very strong immunotherapy program in all diseases here at Stanford. We hired new investigators. Dr. Crystal McKell came in from the National Cancer Institute in January of 2016. She's a fabulous T cell anti-tumor immunity person. We have others that are very, very keen on gene therapy. So at Stanford, this group is really developing at a very rapid speed, and we're hopefully going to have many more trials available than I've shown you here. But now here is one of them. When you look at a tumor under the microscope, the tumor has not only tumor cells in it, there's a lot of other cells. There are white cells, blood cells, there are lymphatic tissues, and all of those can contribute to tumor growth. So you can kill the tumor cell, and you can look for mutation in the tumor cell, but what does it really matter if there are so many other factors that promote the tumor to grow? So what do we do about it? Well, here's some very interesting research that Dr. Irv Weissman has done over the last decade here at Stanford. What he identified is yet another shield. It's called CD47, and he, I think, very correctly termed it the don't eat me signal. Here's your shield again. So the cancer cells are making this CD47, and that tells the other cells, don't eat me. Now, that particular signal is interesting for what we call the macrophages. Macrophages are a subset of white blood cells. And if you remember some of your biology, the Pac-Man type cells in these in the immune system are the ones that I think we would call macrophages that eat up anything. They're extremely, extremely active. Now, how do we get them to eat the tumor cells? Well, it's not that easy, but Dr. Weissman identified this axis here of CD47 and another molecule in the macrophages, SIRP-alpha. Doesn't matter, but if you think about PD-L1 and PD-1, right, same principle. Here's PD-L1 in tumor cells inhibiting T cells from PD-1 via PD-1. Tumor cells do the same thing with CD47, but not inhibit T cells so much. It's more the macrophages. So Dr. Weissman has now designed a study where he takes antibodies again and breaks this here. He blocks these two proteins from interacting, and the macrophages get highly active. That has worked really well in mice. We have to use mice for our preclinical studies. When you look at this mouse here, this was injected with ovarian cancer cells from one of our patients in surgery. In red is the tumor growth. We label those cells with some bioluminescence, and look how these tumor cells grow without treatment. Rapidly, after 8 weeks, these mice are basically full of tumor. Now, you take a mouse, inject it with those cells, and now you take that antibody that breaks the CD47 axis, nothing. And those are now trials going on. We have a few patients with ovarian cancer that were enrolled in the initial phase. It's in development, so keep your eyes out for this. Another trial that I just opened here in our division is what we call a adoptive T cell trial. I was telling you that the T cells are extremely effective in finding the cancer, killing the cancer. But how do we turn this into a therapeutic principle? Well, let's go back to the drawing board here. As scientists, we always like to look at very easy ways of demonstrating things. Here's a T cell. The T cell receptor recognizes the ovarian cancer cell, and this here is kind of like a key into a lock. There's only one key that fits into one lock. The same is true for these recognition pathways. The T cell receptor sees only one antigen on the cell. Now let's imagine you take from a patient these T cells from their bloodstream, and you modify this T cell or these T cells from the patient with the T cell receptor that you want to see this protein in ovarian cancer cells. We can do this nowadays. We can actually take viruses, genetically modify them, and have the viruses transport any gene we want into any cell, so to speak. So that technology is quite amazing. Now, we have a retrovirus that transforms these cells. Now they're all with the T cell receptor. They're all seeing this antigen. In the case of our trial, it's called NY-ESO1. Now, that's not rocket science. NY is New York, and ESO is esophageal cancer. It's been identified in a patient with esophageal cancer first. So this trial is going on. In essence, we take from the patient that qualify those C cells. It's a quite complex procedure in the labs. They're then being reinfused in the patient and hopefully see the cancer and fight it. We have a number of immunotherapy trials going on here. I encourage you to make contact with our clinical trial division, some of which you see here. I run this division. There's a number of very fabulous people in there that can give you some advice on where to direct yourself, what you might qualify for. In, I think, the interest of time, I can't go into all these studies here. This is where we do our work at the Stanford Women's Cancer Center, and this is the division that has 8 different attendings in it. Dr. Karam, Dr. Barrick, who is the chair of the department and the director of the Stanford Women's Cancer, Dr. McLaughlin, English, and then 2 Nguyen and Sujiyama that out at the Velike Hospital in Pleasanton, all entry ports to our clinical trials, and Dr. Teng. So with that, I want to conclude my talk, and I hope that we have some minutes for a panel discussion where we might be able to answer more of your questions. Thank you.
Well, basically that I had a colon colonoscopy early on that the doctor found one polyp. The pathology report said that it was serrated. So I just want to know how bad is that type of polyp.
Yes, good question. So I didn't go into this, but there are different types of polyps. We have hyperplastic polyps, and then serrated polyps, and adenomatous polyps. The adenomas are the precursors, potential precursors to colon cancer, while the hyperplastic polyps are completely benign and wouldn't really require more intense scopes. The serrated polyps, they're actually the ones that have most recently been described. We are trying to figure out exactly whether they increase the risk of cancer or not. But they're sort of the ones where we have a little bit of a question mark.
This question is for Dr. Dorigo. My mother was diagnosed at 45 years old with ovarian cancer and died at 49. What do her daughters, or maybe even the sons, well, they don't have ovaries, but what preventive screenings would you all recommend now, and has that changed over the years? I know we have done the CA-125s and regular exams, but are there other things now that are recommended as far as following the descendants of someone who died young with ovarian cancer?
Yeah, well, I think this is a very important question. First of all, I'm sorry for your mom dying at this very young age. I think being diagnosed at this young age always raises a red flag. And I think that if your mom wasn't screened for genetic predispositions to develop ovarian fallopian tube cancer or breast cancer, I think this should be done in the family. If she was negative, and you knew that, and I doubt that there's any extensive data on it because this was years ago, then I would recommend that the daughters of first-degree relatives go and see a genetic counselor. And what they can provide to you is, first of all, an extensive evaluation of the family tree. They can give you a risk estimate on what the predicted chances that the family has some predisposing genes, and they can run a panel. I think we heard this morning that we don't only test for BRCA1 and BRCA2 anymore. The panel increases. Almost every month there's a new gene that we identify. Now the genes that we add in addition are genes that are responsible for a much smaller percentage of ovarian cancers. Meaning that if you take BRCA1 and BRCA2, those genes are probably responsible for about 12-13% of ovarian cancers. Other genes maybe for 1 or 2%. They're still important. And I think if I could give you an advice that you as a daughter could start this and start genetic screening or at least counseling before and see whether you have any genetic predisposition. If there's any, then a discussion about a prophylactic or a removal of the fallopian tubes and ovaries that we do here actually very frequently at Stanford is very reasonable. We do this via a minimal invasive approach. Those are 20-minute surgeries with a laparoscope, 5-millimeter incisions with a belly button and 2 on the left and right side of the belly. It's general anesthesia, but it's the best preventive strategy we have in the absence of any screening for ovarian cancer. CN25 and ultrasound and pelvic exams, you can do this every 6 months, and the only, I think, governing guideline is from the NCCN, the National Comprehensive Cancer Network, that says that patients at high risk should be screened with these modalities. But we have no good data that shows that that actually can detect ovarian cancer early on. So the surgical prophylaxis is still the best.
Hi, my question is for Dr. Dorigo regarding immunotherapy. So you talked about the immunosuppressive shield with PD-L1 and CD47.
Right.
Are those like tumors? Like, do the cancer cells create PD-L1? Do normal cells create that protein?
Yeah, that's a really good question. Thank you. You know, that's actually a question that has caused some confusion even among my colleagues, whereas PD-L1 actually expressed. So it's highly expressed on cancer cells, and the higher the expression of PD-L1 on cancer cells, the better the response to immunotherapy in general. And every cancer needs a certain level of PD-L1 expression in order to respond to immunotherapy. Yes, it's also expressed on normal cells. And it's expressed on immunoeffector cells, for example, like macrophages and so forth. It's not a molecule that's specific for cancer.
For patients who are in their late 80s who say have had, like myself, who has had a colonoscopy 9 years ago, I don't remember or I don't know what kind of tooth polyps that were found, and who is just lazy in doing the colonoscopy procedure. Not very, just a coward. So basically, are there other things that are really bordering on the gold standard? I mean, really, really bordering on the gold standard, so it could be avoided, the big one.
Excellent question. So first of all, I'll say, so for someone who has had normal colonoscopies, or at least no personal history of colorectal cancer, the guidelines actually say to stop the screening colonoscopies at age 75. So if you want to follow the guidelines strictly, you could stop. But of course, I mean, age is a relative term, and so for someone who is healthy and healthy, and you could consider doing something like the fecal occult blood in the stool. It is less sensitive, but it's still, if it were positive, that we would recommend for someone with a positive stool test to have a colonoscopy then. Yes.
And one final thing, IBS and its similar sound, I'm so sorry. Thank you for taking a second question. I know that irritable bowel syndrome or so irritable issues, but I have had a lifetime of those practically, and am still here at 87, and I'm that coward that I just spoke about. So if I survive, normal other issues. Again, I could possibly adhere to the 75.
I think so. I think so. Yes, and I would like to be clear because I spoke about inflammatory bowel disease. That's different from irritable bowel syndrome. Inflammatory bowel disease, people have actual inflammatory changes and will have symptoms like diarrhea and blood in the stool and lots of belly pain. While irritable bowel syndrome, 40% of the population has irritable bowel syndrome, and that does not increase the risk of colorectal cancer.
Thank you so much.
Welcome.
I think I'm next since I have the mic in my hand. Question on testing. If someone has ovarian cancer and they are positive for the BRCA gene, at what age should their teenage daughters be tested?
Great question. So I think you heard this morning that the prophylactic strategies are not recommended before the age of 35, the surgery. So that's still, it's probably going to move up in the future, but it's still 35. I think that as soon as it depends a little bit on when the first-degree relative was diagnosed. And we like to start screening years prior to this. And it depends on what guidelines you're reading. Some guidelines say 5 years, some others say 10 years prior. The problem is screening for ovarian cancer, we don't have that. A teenage daughter, it's way too early to screen them. So, yeah.
So you're talking about the actual genetic testing, not the oophorectomy, right? Is that?
Yeah, so we're talking about a patient that is BRCA1/2 mutation carrier. She has the diagnosis of ovarian cancer, and now she has daughters. When should they be tested? Yeah. So, we don't really recommend testing teenagers because it won't have any consequences. As soon as they get in their 20s, particularly 10 years prior to when the mother developed ovarian cancer, is when you start having to be worried, right? I have seen patients, I recently had actually 2 patients here at the age of 18 that develop ovarian cancer. And that's very rare. And they're still not genetically screened, but here you've got to be very worried. But this is extremely unusual. So as we identify more and more genetic mutation carrier outside of BRCA1/2 mutation, we got to think about this issue very carefully. You also have to think about the psychological impact of testing on a 15-year-old little teenager that can't face these issues. Even for us adults, it's very complex to think about it. And I think if you postpone the testing, in 10 years from now, we will have larger panels, right? We're going to have larger panels next year. So I think that those things can be postponed till they get into their 20s. I don't know what I can.
So, and the girls are late teens.
So yeah, I would echo Dr. Dorigo. I would say usually the recommendation in cancer genetics clinic is to start a discussion about testing for BRCA1 and 2 around 20 to 25. And in terms of what we would do around that time, if you do test positive for either of those 2, is to start MRI breast screening at the age of 25 yearly. And then we would add a mammogram at the age of 30. Some of the issues there is, again, the breast density, and that's why we don't recommend mammography earlier. And also there's this theoretical risk that if we expose the young breast to a lot of radiation, that we might actually increase the chance of cancer development. And so really 25 is when we do the MRI breasts. 30, we add the mammography, and so usually what we recommend is to do it every 6 months. So at 6 months you do MRI breast, and then 6 months later you do the mammography, and you kind of go back and forth sequentially between those 2 modalities. So really, there is no need to screen very early because we wouldn't necessarily do anything in terms of procedures. Certainly, we would still recommend a monthly breast exam and a clinical breast exam every 6 months in the case that someone has a BRCA1 or 2 mutation. The breast exam is primarily just for the woman to just kind of get to know her breast. It hasn't actually been shown to increase the risk of finding a breast cancer. But being a breast oncologist myself, I do see a lot of patients who do find their own breast cancers, and I think it's really important to just make sure that you know what a normal feels so that if something is abnormal, you know when to call your doctor.
We have time for one more short question, and then hopefully the speakers can answer other questions later.
Okay, so my brother was diagnosed with colon cancer at age 44, so he had never had a colonoscopy, but and it was stage 4 by the time he found out about it. But he recently went to Hawaii to get a silicium molecule injection. Is that a study that you're familiar with? It sounds like it's the same idea as the Nivolumab, where it goes in and breaks down the hard shell of the cancer cell. And I might not be saying it right, but it's something like silicium or salicium. I just wonder if you have any studies about that.
Mm-hmm. Yeah, so first of all, if he was diagnosed at age 44, then his children should start having screening colonoscopies at age 34. Definitely important to screen the family for Lynch syndrome if that hasn't been done. In terms of the drug you mentioned, I'm not familiar with it. But if the cancer is microsatellite unstable or related to Lynch syndrome, then definitely trying immunotherapies would be appropriate in the setting of a clinical trial.
With the Nivolumab.
Nivolumab, yeah, there are two drugs, Nivolumab and pembrolizumab. They are approved for other cancers, and then there are a bunch of investigational options as well.
But not for colorectal cancer.
Yes.
They're not approved in colorectal cancer, no.
But for trials, yes, it's mostly those MSI positive tumors that respond to this. So if your brother wants to be screened, I think you have a trial, I think still open here with Dr. George Fisher as a principal investigator. The reason why I know this is because endometrial cancers also qualify for this treatment if they are MSI high. So
I think he's spoken with Dr. Fisher, and
yeah.
I don't know if he's asked specifically about a trial, but I'm sure he would have offered it if there was one that was appropriate.
Yeah.
And okay, one really last quick question. What about siblings and our children? So would my children also start screenings at 34?
So the siblings should definitely go and have colonoscopies. In terms of if the family does not have Lynch syndrome or an inherited cancer syndrome, for someone who has a second-degree relative, the guidelines say start at age 50 when it's not a first-degree relative. If there are two individuals in the family, though, with colorectal cancer, it might be appropriate to start earlier.